Good morning. Good morning. I'm Jeff Ladinsky, and we're coming to you from South Sebring. We're going to talk about integration of manual and balance therapies. So the question people have, what do the two have in common? Well, that's what we're going to talk about in this session. So hang on, and we're going to start at the beginning. Why would we integrate manual and balance therapies? Well, one of the things that we have to do is we have to be a little bit more judicious with our treatments. That is, we have to pack more bang for the buck. And so we have to look at the patient as a whole. So one of the concepts of function that all physical therapists have, it's always been a cornerstone of what we do, but the evolution of how we achieve function has changed over the years. So we just don't look at one area of the body and neglect other areas of the body. So the idea of having manual therapy working with vestibular therapy has come to light over the past several years. So the first question I have is, in your mind, obviously you can't shout it through Facebook, what is the most important muscle in the body? And we're not talking about hard or smooth muscle, we're talking skeletal muscle. What muscle would you think it is? And we'll get back to that in just a minute. If you had joined me with an earlier Facebook cast we talked about balance, specifying specifically inner ear function and dysfunction of the inner ear. But now let's talk about balance as the whole, incorporating all three senses of inner ear, ocular, and somatosensory, which is the pressure and joint receptors in our legs and throughout our body. Balance is simply the center of gravity over the base of support. So anytime that our center of gravity shifts over the base of support, we must move the base of support under it in order to maintain balance. If not, we have possibly the F word, which we don't use around here. We prefer to call them acute gravity attacks. So anyway, your balance system again is your eyes, your inner ear, not your hearing. Hearing is located very, very close to your balance center, but really doesn't have much to do with it. Here's your hearing, and this is your balance center in the center of your skull. Okay, so without, again, rehashing the anatomy of that, we may come to it a little bit later, but understand those three senses will come together to form. Now, anything that affects any one of those senses will affect balance. So understand, ocular problems, people with macular degeneration or other eye pathologies can have balance problems. People that have orthopedic problems such as knee problems, back problems, hip problems, and foot problems can also have balance deficits. So therefore, we must take into account those orthopedic diagnoses with our vestibular diagnoses that come our way. So somebody who has ataxia, it could be coming not just from problems with the inner ear and the brain, it could also be coming from an orthopedic problem of arthritis in the feet, arthritis in the ankle and knee. So we have to take that into account. So one of the hallmark ideas that we have is, who treats this? Who treats balance, these integrative balance problems? Well, again, we have three healthcare professionals here. We have the ophthalmologist, who obviously takes care of the eyes, okay? And we have the ENT, where their specialty, again, is the inner ear, as well as the nose and throat, hence the name. And then you have physical and occupational therapists, and our domain pretty much is the musculoskeletal arena. But again, I told you that balance is an amalgamation of all three senses. So who treats this area right here? Well, I dare to say most people have not gone to the ophthalmologist and had to stand on a balance, foam balance to test their balance. Whereas an ENT may test your balance, but do they check your eyes? Or do they look at how your eyes integrate with the other balance senses? And the answer here with physical therapy and occupational therapy is we handle the musculoskeletal or the somatosensory, which we primarily deal with the strength and coordination. But who's best to qualify to bring all three of these together in this little area here? And the answer is us. So it is us, it is our responsibility, because if we're going to optimize movement which is our goal, then that includes integrating these three senses. Okay? Now, let's go back to the question I asked just a few minutes ago. What's the most important muscle in the body that one feels like is important in balance? And the answer is the iliopsoas. Okay? Now, we can have debates. It could be your core musculature, it could be your gluteal musculature, but think about the iliopsoas, okay? Think of where its proximal insertion is on the lateral anterior section of vertebrae 1, lumbar vertebrae 1 through 4. So, pardon me, this is Earl. Earl's going to be assisting us here with some demonstrations. So 5, 4, 3, 2, 1. So if we kind of put our makeshift iliopsoas in here, you can see that it encompasses the transverse process, it encompasses the disc, and it's quite, the proximal insertion is quite broad. And then it blends in the the psoas blends in with the iliacus muscle, and then it joins down here and attaches right here on the lesser trochanter of the femur, okay? So what happens now is you can see that any kind of tightening is going to influence the lordosis, or it's going to influence the movement of the femur. So if I have facilitation or tightening of this muscle, it's going to make it difficult to take a full step. So let's start from the beginning. If I'm sitting, okay, my iliopsoas is in a shortened position, but it does. So therefore, a lot of people don't have trouble sitting. But when we go to get up and there's facilitation, we're going to see how this has to elongate. But if it's in a facilitated position, it's going to be awkward, and that's why the first few steps may seem quite difficult until that muscle tends to loosen up. But then over the course of standing, we tend to go more into that anterior tilt, and therefore our center of gravity is going to be thrown posterior or to the back. So this muscle is quite insidious because this happens to us over the course of years. Think about most of our lives. Most of our lives are sitting, computers, or we work in an area like this. So over the years, this tends to slowly but surely tighten. Well, again, if I tighten over here, it's going to make it difficult for this leg to go back this way because it won't stretch. So I'm going to start taking smaller steps with my other leg. So this, again, leads to gait deviations, which again can lead to balance problems. The pelvis is tilted forward. So what happens is when this occurs, we call this a functional lesion. In other words, the balance between, if this is a tent pole, and I have tightness of one rope, this is going to be short and tight. The other rope is going to be long and weak. And that's one of the concepts that we need to look into, and that is, and let me bring this up here, of what's called cross syndrome patterns. Okay, and what this is a predictable pattern of shortening and a predictable patterning of lengthening. So let's take example. Let's go back to Earl here. If Earl has shortening of the cervical or neck extensors, these muscles are going to be short and tight, thus tilting the head backwards. That's going to lead to elongation or lengthening of the cervical flexors. They're going to be long and weak. Short and tight, long and weak. Okay? Well, this cross pattern of facilitation means that if we go down and across, we're going to find the same situation in the upper part of the chest. We're short here. We're going to have short and tight musculature in the chest area. In other words, our pectoralis minor and pectoralis major to some degree are going to be shorter, thus influencing everything forward. Well, here's the pattern of weakness. We've got lengthening of the cervical flexors. If we go down and across, we're going to have the same thing of the scapular retractors. So the shoulders are going to most likely be pulled this way and possibly tilted forward because of the influence of pectoralis minor. So again, that leads to what we call the forward head syndrome. So if this is forward, the head is forward. And one of the what we talked about the last time we got together was the further the head is from midline, the less accurate the inner ear will be in predicting the body's position. okay? So the further my head is away from this imaginary plumb line, the less accurate my inner ear is going to be in determining my balance. So we always want to keep our head as close to midline as possible. So you can see the influence of just this upper body cross pattern facilitation and inhibition. In other words, this is long, elongated, and this is shortened. Well, muscles work in pairs. If one side contracts, the opposite side has to lengthen. If one side contracts, the opposite side has to lengthen. If both fired at the same time, we'd have no movement. So therefore, if I'm chronically held in a shortened position, the tissue will shorten and thus send inhibitory signals to the opposite side to, hey, you know, I got this. So it's not going to fire. So we're going to see that throughout the body. So if we jump back down to where we were talking about, where we have the facilitated hip flexor, that is going to inhibit one of the largest muscles, the most powerful muscles in the body, and that's the gluteal area. Not just gluteus maximus, but gluteus maximus has two brothers, gluteus medius and gluteus minimus. They're also affected. Gluteus maximus is what helps us get up and down from a bed, from a chair, go up a step. Whereas gluteus medius is a little bit more out this way. That's what helps us walk. That's what helps hold our pelvis level when we go to swing our legs. So you can see how important that is in the big picture here. So again, facilitation of the hip flexor can lead to weakness here. Let's go up and across. The low back is always tight. When have you ever, clinicians, when have you ever felt extensors that were loosey-goosey? They're usually pretty tight. And if the tighter they are, they're going to thus influence the inhibition of the abdominal musculature. Okay? So anyway, that's a little talk about the cross pattern, which does, when a patient is involved deeply in that, it's going to affect the outcomes of our vestibular therapy when we're trying to retrain the balance system. So, again, in quick review, where you think it is, it ain't. That's a famous saying from a clinician years ago. And what they're saying is, even though the pain complaint may be here, the source may be elsewhere in the body. So we must look not just one joint above and below. We have to look way above and way below for these pathologies. So again, let's take this to a clinical example. If I've got facilitated hip flexors, my pelvis is going to lean forward, and thus, therefore, what's going to happen is I'm going to get some internal rotation because, again, the iliopsoas is an internal rotator. And what it'll do is it'll internally rotate my femur. Well, the body always wants to make contact. The joint always wants to make contact with the surface. So it's going to compensate, again, by further internally rotating. So now I've got this gapping at my knee because my femurs have internally rotated. Well, my tibia doesn't like that, so it says, brain, you got to help me out here. So what's the brain going to do? The brain's going to then rotate my shins, my tibia, and in order to make good contact. Well, we're happy here, we're happy here. Well, now the ankle is not making good contact because of this change of position of the shin bone. What do we do here? Well, the foot's going to complain to the brain. The brain then is going to bring the foot inward. So if you can imagine, I'm exaggerating, but now I'm going to have, my arches are going to start weight bearing. In other words, we're going to have increased weight bearing here. So this is typical of a lot of our patients. They're in a posture very similar to this. So what do? Well, we're going to throw orthotics in here, and then we're going to re-establish neutral at the feet. Well, we did that, but now the knees are going to say, well, we've got to go back to here, and we're back to where we started. So what happens is the body's going to fight the orthotic, and oftentimes what happens is we don't treat this problem. The patient's going to say, you know, my feet are killing me with these orthotics. I was better off without them. So sometimes we put orthotics in, and we do not retrain the positioning of the pelvis and the hips. We're going to have this problem. But getting back now to how this affects balance. We're going to go ahead and talk briefly, again, about the inner ear and its influence on balance, as we had said earlier. Again, the further the head is away from the midline, the more likely we are not going to have accurate reporting of head positioning. Okay? But if we're forward here, it's going to throw our center of gravity towards the posterior, so the body has to compensate. Well, there's a lot of other issues that could be going on because, again, if there's a problem with the inner ear because it's forward, there's a problem with the somatosensory area because we've got peripheral neuropathy. In other words, we've got numbness in the feet through both cardiac and possibly diabetic neuropathy. These problems now, we have a strike 1 and a strike 2. The only system that doesn't seem to have a problem is our eyes. Well, we have natural degradation of our vision as we get older, but we have other diseases like macular degeneration, cataracts, and things of the like. So we have inhibition in all three systems. That's going to affect balance. Okay? Well, if I have decreased sensation in my feet, I can't tell my inner ear balance harder because how do you make the inner ear balance harder? Well, it's physiologically impossible because it only sends signals to the brain. In other words, the brain can't tell the inner ear to work harder. It's only a one-way signal. So that only leaves the eyes as the only other substitution we have if our feet are not working. Of course, what we'll also do is we'll actually enlist the use of the hands. And these are our folks that kind of walk around. We call them furniture or wall walkers. And they'll use their hands wherever they can to help give feedback to the brain where the feet cannot. But what we do is these people tend to stare. They tend to lock their eyes on the ground. So they're going to use their ocular or visual cueing to help with balance. Okay? So that's the substitution that's going on. I've got tightening here, weakening here, going all the way through my lowers. My center of gravity is forward. I've got macular degeneration. I've got orthopedic issues that I don't like to stand on this foot because I have pain. So I have all these going on. So where does a deer therapist begin to start to treat these people? And the answer is in the middle. You start in the middle, okay? Correct the pelvis, and then you can start to work on other issues to, again, try to bring the body in line with that imaginary plumb line, getting the head here. Now, if the patient has benign paroxysmal positional vertigo, again, you would treat that first. That's the inner ear problem we spoke of before. That's precedence over everything. Once that's clear, everything else we need to is predicated on postural neutrality as much as possible. If there's an ocular problem integrating with the ear, we still have to make sure that the patient can get close to neutral. Otherwise, the ear is not going to work as well as it can. Okay? So again, the order of importance is very, very important for what we do. So what we usually do with that is with the integrating the manual therapies, which again, a lot of clinicians are very comfortable with the manual part of it, of doing stretching, both static and more importantly, dynamic stretching. Mobilization if you feel that a certain joint may have a restriction. Right. So we do that to create the normal mobility inside in the pelvis. So we neutralize that. But where I think we ended there, right. And remember, if we're stretching something, we have to strengthen something. It's only half the job. If you decide you were going to stretch the extensors, you must facilitate the flexors. Okay? Otherwise, these extensors are going to go right back to the shortened position because there's nothing to keep it in that elongated state. In other words, it's going to seem unstable. So again, putting all this together will again help us neutralize the pelvis better and have a more lasting effect. We're going to take that part there, and then we're going to integrate it with the vestibular problem or the vestibulo-ocular problem. Okay, so we do that. And what we do is we also tend, as therapists, we neglect probably the strongest of the three balance systems is the eyes. That is the strongest in terms of visual feedback. It is very, very important. Okay, we've got multiple areas of the brain where these signals go, not to mention how many cranial nerves serve the eye. And the answer is? Right, 3. Yeah, I heard somebody out there said 3. Okay, so that tells us that the vision is very, very important. in human movement. So what we do is we tend to forget that when we deal with balance. We tend to work solely on the somatosensory aspect of how are the joints doing. You know, let me strengthen the legs, that'll improve balance. Well, it will to some degree, but not all the way. So what we have to do is we start at the top, and the top is ocular testing. Okay, we test the eye movement. Now, there are three conditions for eye movement and head movement. The first one is a static head, eyes moving. In order to achieve that, that is purely coming from the brain. In other words, it's using those three cranial nerves directly from the brain to the eyes just to track across the field up and down, and also as far as accommodation of objects. So those are the first things we do. We look for any kind of deviation. Is there smooth pursuit? Is there eye slippage? Is there nystagmus, which is an involuntary jerking of the eye? We look for that. We go from there to the next part is then we take the eyes and integrate it with the inner ear. Now we've already checked for BPPV. That's the first thing we should always look for. And if negative, we go on then to the inner ear, to the eyes. If the eyes are clear, then we're going to look at the integration with the vestibular system. So what we're going to do here is we're going to fix the eyes and move the head, because remember, it's the head movement that triggers the inner ear. When my head is still, the inner ear is not saying anything because it couldn't care less that my arm is moving. It only cares about what the head is doing. So therefore, we look at the eyes. If we do find something with the eyes, we make a note of that. But then we're going to see how the eye integrates with the inner ear. And we make a note of that. So if I am not able to maintain eye contact when I move my head, or if I start moving my head and I start getting symptoms such as nausea, I start feeling like I'm off, what do I do? Okay, well, I make a note of that. So what we're going to do next is the third condition is the eye and head moving together. And what happens is that we're now getting a cerebellar. This is where it takes place in the cerebellum, and that's where our somatosensory comes in, and we can see if there's a deficit in the somatosensory system. So each one of these ocular integrative movements will help us determine what kind of plan of care we want for these patients. So again, inner ear, BPPV first. Check the plumbing. Make sure there's no clogs in the system here. Number two, ocular. Check the eyes in different positions, across, up and down, diagonals, okay? So what we're going to do then is then we'll go down to somatosensory. All right, then we can also then integrate all the above with movement. So then that's where we start from sitting to standing to movement. So that's the order that we go with the vestibular progressions. So let me fast forward here. When we determine what we're going to do with our patients, what we're going to do here is we're going to take these interreliant systems and work on them individually and then bring them back collectively. It's much like an orchestra. Okay, you can have a wonderful brass section, a wonderful string section, a wonderful percussion. But when you put them together, they may not sound right. They may not work well together. So if you start working them together a little, one group at a time with the other, then things will sound better. What'll happen with the body? The same thing. Instead of noise, you're going to get music through the body. Okay? So the manual therapy is to prep the body and get it closer to neutral. The closer we can get the body to neutral, the more mobility we can give our patients, as well as stability. And from the stability, we can have what's called controlled mobility, movement around the fixed point, and then eventually skill. Skill being walking, transferring functional ADLs. Okay? So that's a brief overview of how manual therapy can be amalgamated with vestibular therapy to be more effective in treating not just orthopedic, but also vestibular patients. Okay? Now, my name is Jeff Ladinsky. Again, I'm the clinic manager here in South Sebring. And I invite you to tune in again soon for our next Facebook Live presentation.